if you'd come to the table, committee. Questions? Okay, Jeff Botkin and then Alta.
Yeah, all great talks. This question for Laney is just about what's happening in the market now. You've sort of described much more knowledge about the potential benefits and perhaps amelioration of some of the early excitement about the impacts psychologically and height-wise with treatment, and then more knowledge about the risks, and a fairly long list there. So how's that better knowledge impacted the marketplace? Are clinicians using this readily now, or have we seen a decline in interest in this, or what's been happening?
I actually don't have that data. What I can say is that I think to the extent that when parents come requesting it, there's a much more robust consent process, given that we actually now understand that the benefits for short children who are non-growth hormone deficient really is a very small increase in height for a lot of treatment over a long period of time for a large cost. So I think there are still families who are seeking it and demanding it, but I think the excitement is worn off both in the public as well as in the docs.
Alta. Oh, okay. Okay.
Sorry. Lainey, if we were to try to take this situation and then apply it in the context of the mitochondrial replacement therapy, the analog, I think, would be a little, it's slightly different. I mean, none of these were perfect, right, parallels. But it would be clearly dealing with an actual disease. I don't think there's anybody who questions that some of these effects of the mitochondria or disease effects. But Kevin Fitzgerald this morning talked about how once you're going to replace the mitochondria, why don't you replace it with the best mitochondria? So that's where I think he introduced this notion of treatment blurring into enhancement. So if we were to go back to the human growth hormone and we say, if we were clearly treating the growth hormone deficient children for whom we clearly call it a disease, would there be anything wrong about deciding that as between two different kinds of growth hormone treatments, we would use the one that was going to achieve the greatest increase in height as opposed to just using random ones that might increase height more, less, or in between?
Yeah, I think I want to tweak what you just said, because I think the analogy is better to say, are we just going to bring them up into some average height range, or are we going to actually try to maximize their height? Right? Because that's what the real question would be. Are we trying to get the best mitochondria? Are we trying to get the maximal height? And traditionally, what the endocrinologists have done is basically said, what would your height have been had you not had the treatment that led you to be growth hormone deficient, whether it was the treatment for the brain tumor. And so therefore trying to get 9 inches for the kid who might have lost 9 inches and only 4 inches for the other kid, which then, but again, that's only part of the issue with growth hormone deficiency, because to the extent that there are other implications of growth hormone deficiency, some of the psychological and cognitive impacts that it has by being growth hormone deficient, you actually do want to use this treatment not just until you've reached adult height, but you could actually argue throughout all of adulthood. And it also does have an anti-aging effect, and so people might want not to, to have that same anti-aging effect that the rest of us have. And so therefore it becomes a lifelong treatment, which raises a whole other set of cost issues and access issues.
I would add one thing. Once endocrinologists told me the way they would decide when to stop growth hormone treatment was when the person was taller than the endocrinologist. But the other thing I think that Laney's example points out is that our abilities to actually make it work effectively in terms of height were not met with as much success as we thought. And I think the same might be true with the issue of the best mitochondria. In other words, I think that's really probably a false question at the current time, and I think that will distract us.
So certainly in the market for egg donation, people have the idea that they are finding the best possible egg donor. And so I would really question whether or not this is even possible to identify in the realm of
I'm not suggesting it actually is, but I was trying to figure out how to use what I was hearing in the context of our discussions.
Yeah.
Vamsi.
If I understood properly, the definition of clinical short stature was less than 1% on the growth curve, is that correct? And so there's obviously variation in the distribution of heights from one ancestry group versus another. So I'm wondering, that 1% is based on what background distribution? Is that a Northern European background distribution?
So the traditional growth curves that pediatricians use here is based on Midwest farm children in the 1950s. But nowadays, for example, in the electronic medical records, I can choose to use the World Health Organization growth curves, which is the one I use for most of my patients.
So I think this is going to be, an important consideration for MRT as well, because when we ask the question of what is a serious mitochondrial disease, it could be the type of disease that we heard about earlier today, which is meal loss. It could also be diabetes. And I think similarly, what is the definition of short height really depends on your cultural background and what you accept as a healthy height or not a healthy height.
And just to finish with that, it also gets to the other extreme, which we didn't talk about, which is too tall, right? If we're going to call short stature at less than 1%, then what about the 99th percentile? And had I finished my talk, I would have given an example back in the 1970s and 80s where we treated tall girls with high-dose estrogen and DES, not realizing that the impact it would have in the next generation in the sense of causing infertility. So the idea of calling the 1 percentile, which is just a bell curve, not normal distribution, disease becomes very problematic.
Marnie.
Yeah, so that was very helpful. So as a clinical geneticist, I've seen over the last 15 years people change very much their approach to using growth hormone. In the past, it was you had to have defined growth hormone deficiency, and now it's give it a try and see what the first response is and see if you get a response and then keep going. So the threshold has definitely changed. That said, the endocrinologists still fear bad side effects like things you didn't mention, like pseudotumor cerebri, right, which happens, which is a severe headache and intracranial pressure changes and sometimes permanent visual changes. So the more you do, I think that the discussion changes, and that's likely, in any indication.
I would be hoping even that approach of let's give it a try is starting to go away, because what we've come to realize is a lot of that give it a try gives them a short-term burst in height, but in the end only gives these kids more or less a 1 to 2 inch maximal increase in height overall. And so just because you can increase it quickly doesn't mean you're going to get the real gain, which is what you're looking for.
And I guess my bias is I see it in kids with genetic disorders. So when like Prader-Willi used to say if there was defined growth hormone deficiency, give it. And now Susie Cassidy, who's sort of like the guru, says just give it.
Well, and
so it has changed.
And
yeah.
they're doing that for Turner syndrome. So for some of the kids with the genetic disorders, and I did point out some of those, there was specific approval given for it. I think where the switch over has really become in just the healthy, non-growth hormone deficient short child, the child who is idiopathic or familial short stature.
Great. Thank you. And we'll be able to maybe consolidate a little bit of this at the end, but I want to move us on to the fourth example.
Can I make one last comment before?
Very, very short.
Very, very short. After I was asked to give this, I fretted over whether I should actually ask to give a totally different talk. And I just want to mention this so that the panel can think about it, which is the whole issue of uterine transplants. Because today, as we were talking about genetics and epigenetics, the idea of using there has been a successful case of a child born to a woman who was given a uterine transplant. Some of the uterine transplants are from other living women, usually either their sisters or their mothers. So you do have then the epigenetic impact of either your sister or your mother in the uterus in which the IVF embryo is going to be implanted. And so it raises some very interesting epigenetic impact, which might be another interesting policy analog as you think about mitochondrial DNA.
Thank you for that. A short comment, but very provocative.